Hi, it's John again, and we're going to go ahead and talk about another patient, 76-year-old female with severe substernal chest pressure. And with every AKG, the first thing you want to go ahead and do is look for the rate. We're going to go ahead and look at lead 1. We can go ahead and look and see that here 300, 150, 100, and then 75. And it looks like that the rate is between 100 to 75. It's neither tachycardic or bradycardic. So we have a rate between 75 to 100. Another thing that we're going to look at is rhythm. So the first thing you want to check, is there a P before each QRS? And is there a QRS after each P? And I'm going to try to see if I can find a P here. You can appreciate in V1 that there's a P for every QRS. P for every QRS and a P for every QRS. And is there ever a QRS for every P? And there is indeed a QRS for every P. QRS every P. So now you want to go ahead and look at the PR intervals. Here P, QRS, P, QRS, P, QRS. And I do not appreciate any prolonged Q intervals or PR intervals. And you look at the QRS and you see, is there any widened QRS complexes? And yes, you do appreciate that in V5 and V6. Also, you can appreciate a little bit in V2 and V3. So definitely there is a widened QRS complex. So what I wanted to go over today here is that if you look at the arrows, the EKG shows basically a sinus rhythm. And you look at the arrows, here you can appreciate some on leads V5 and V6, some ST segment elevation. And this is consistent with acute injury pattern. And also, if you look at V6, you do appreciate what we call a left bundle branch block. So how do we identify bundle branch blocks? I know in the last discussion that we had, we were discussing a complete right bundle branch block, and in this one we're going to talk about the left bundle branch block. So in order to make the diagnosis of bundle branch block, the QRS complex should be at least 3 small squares wide or 0.12 seconds. The right bundle branch block looks at leads V1 and V2, and in the left bundle branch block you look at leads V5 and V6. And if you go back into this EKG, you can look at V6 and you can appreciate the left bundle branch block. So in left bundle branch block, the right ventricle depolarizes before the left ventricle. So the first portion of the wide QRS represents left or right ventricular depolarization. So if you look, the first R wave represents the right depolarization because the left is blocked. So that's what answers the question. Also, another thing that I just want to point out is that the most specific finding for an acute injury pattern in the setting of a left bundle branch block, right here, is concordant ST segment elevation, which I already previously mentioned in V5 and V6. Also, in the setting of a left bundle branch block, acute MIs is very difficult to diagnose, and the usual criteria do not apply. Q waves are often normally present in the anteroseptal leaves and cannot be considered pathologic. So, if a concordant ST segment elevation greater than 1 millimeter, so here in V5 and V6, is an unusual finding in left bundle branch block and is generally considered to be a sign of myocardial injury. Okay, that's it.